Good morning, good afternoon, good evening, everyone, wherever you are. I would like to thank Dr. Gianluigi Pinzan and Fabio Taccone for the invitation to participate in this E-Day on ARDS. So the corticosteroids has a strong anti-inflammatory action by means of effects on multiple signaling pathways. From this image that has been published in an editorial by Peter Suter in New England Journal of Medicine 2006 was an editorial to the ARDS NET trial in 180 patients with established or persistent ARDS, which receive steroids beyond the 7th day. So the corticosteroids can switch on genes activating and coding anti-inflammatory proteins, or can switch off genes that are activated during inflammation. This is what we call the cytokine storm that was very popular during the COVID pandemic. However, the ARDS is not the only syndrome in this umbrella of the cytokine storm. Hematologists, oncologists, rheumatologists, infectious disease people are aware of this storm, as you see here in this from this picture. Historically, the corticosteroids were the cornerstone to treat these cytokine storm syndromes to reduce disease severity. Based on the observational studies finding from randomized controlled trials, the determinants of clinical efficacy of corticosteroids in ARDS depends on timing of initiation, dose, mode of administration, duration of exposure, dose tapering. Due to the to the very tight time that for this lecture, I strongly recommend the readers and the audience to read these two papers published by Meduri and colleagues in intensive care medicine in 2020 and 2021, just this year, to know more about these issues, because I think it's very important. We don't have a complete answer to all of them, but at least you will have an insight on each one of them. So, in fact, with Meduri and other two colleagues, we decide to assess the impact of corticosteroids on hospital mortality in ARDS patients without COVID. Just was in March during the initiation of the pandemic of COVID-19. This we evaluate and assess and analyze 10 randomized controlled trials, including more than 1,000 patients from 8 countries. And the net effect of the corticosteroids was the beneficial to save life at the time of discharge from the hospital. So using a different methodology, in a recent issue of Intensive Care Medicine, Arul Kumaran, I don't know if you have to say Arul Kumaran, they listed there's almost the same randomized controlled trials, and they add the recovery trial in COVID patients. This is in ARDS, and they found something that is familiar with most of you, that most randomized controlled trial has less than 100 patients, that the definition were different, the use to enroll patients, that the initiation timing for giving steroids were almost different in all of them. In fact, in the recovery trial were not stated. The type of corticosteroid was different in all of them, and the risk ratio for death was very different in all of them. I am going to focus in the last two, not only because it's the newer one, but it's because are related to the DEXA and are the larger one of all those randomized trials, and the net effect was a decrease in mortality rate, overall mortality rate. So in the DEXA trial that was published in the first week of February 2020, so before the pandemic, the dexamethasone during 10 days was associated with a reduction of 15% absolute reduction on 60-day all-cause mortality in patients with ARDS from several etiologies. We found that the most beneficial effect was found in patients with pulmonary or systemic infections. I mean, the ARDS was due to pulmonary or systemic infection. In fact, when we decide to analyze in more detail pneumonia, we found that the viral pneumonia, the dexamethasone has more effect. I mean, the reduction in mortality rate was bigger in patients with viral pneumonia than in bacterial pneumonia, something that was against our, the reported data, in fact, and was unexpected to all of us. But essentially, what we found that the dexamethasone was effective, corticosteroid was effective in the treatment of ARDS caused by sepsis or pneumonia. In the recovery trial, this is now with patients with COVID-19, we don't have data on the number of patients with ARDS, but the number of deaths in patients with acute hypoxemic respiratory failure receiving mechanical ventilation was reduced by 12% in their publication. You know that the COVID, recovery report was press released at the end of June and was published a couple of weeks later in the New England Journal of Medicine. Compared to the DEXA ARDS trial that I mentioned, 60-day mortality, the recovery only report 28-day mortality. We don't have ICU, hospital mortality, or 60-day mortality. Well, this is not in a slide to read, but after the recovery was published or even released in the press, all randomized controlled trial testing corticosteroids were stopped for not only for ethical reasons, but the signal was already positive in the recovery trial. So under the leadership of the World Health Organization, we decided to do a prospective meta-analysis with all those trials that were stopped. At the end, we collect information from 7 with almost 2,000 patients from 12 countries. Of course, the definition of critical ill patient were different. Some of them has ARDS, others they don't have ARDS. Some of them were ventilated, others were not ventilated. But that was published in September issue in JAMA. But in that meta-analysis, that the patients were treated with different steroids, dexamethasone, hydrocortisone, methylprednisolone. Again, the net effect on 28-day mortality was positive, okay? And with a reduction in mortality rate in about 1/3. So based on the recovery trial and in this meta-analysis, the World Health Organization published 2 recommendations that now are a standard of care to treat a patient with COVID-19. One is that they recommend systemic corticosteroid in patients with severe and critical COVID, and we suggest not to use corticosteroids in treatment with patients with non-severe COVID-19. So, however, we have more questions than answers. For example, which one to use? There has been already 3 type of corticosteroid that were present in those randomized controlled trials. It seems from the data that we have that dexamethasone merit priority. When? to use it. When to initiate treatment, that is very important to for this for its efficacy. Well, ARDS onset within 24 hours later. Well, we think that if the patient is intubated, if the patient is mechanically ventilated, um, earlier, I mean, the ARDS onset is better than later. So I think that ARDS onset merit further attention. Which dose? Low dose, medium dose, higher dose? It seems, according to the experts, that the dose should be near the corticosteroid receptor saturation. In the case of methylprednisolone, it's about 80 to 100 milligrams per day. In the case of dexamethasone, it's 20 milligrams per day, like we use in the DEXA ARDS trial. For how long? 10 days, a week, 14 days, 28 days? Well, based on the results of the recovery and in the DEXA ARDS trial, because we are talking about ARDS, not only all kind of hypoxemic respiratory failure, I think that 10 days may be priority. It doesn't say the last word, but we know that it's important, the timing of initiation of treatment with steroids. But this is in two beautiful papers published and very recently, this year, observational studies, one in the United States, in which in the absence of mechanical ventilation, the authors found that if the patient is still hospitalized at 72 hours, you should give steroids. I'm talking about patient with COVID-19. In this study from Spain, the authors found that the early corticosteroids, once you are admitted in the ICU, or once the patient is admitted in the ICU, are associated with lower mortality. So I think the earlier, the better. But I'm talking about if the patient is already intubated, you should treat it because it's the standard of care according to the World Health Organization and in the recovery trial. So there are new studies, at least I found these three, there are more. They are going to tell us at the end when they finish something about the dose, the duration, the type of corticosteroids, and whether dose tapering is needed. One is the COVID steroid 2 in Denmark, in other countries too. The Dexa Refined is going to be in Spain, and the Medias in Italy. One is in COVID, the other one is in patients with acute respiratory failure from infections, by infections, and in the Italian one is in COVID-19 pneumonia. So I would like to conclude that we have strong evidence, I think we have it, that corticosteroid can reduce the risk of death in patients with ARDS. This is based mostly in the ARDS DEXA trial. We have strong evidence that corticosteroid can reduce the risk of death in patients with non-ARDS acute hypoxemic respiratory failure. This is based in the recovery and in the meta-analysis after the recovery. And to takeaways, so we don't have at the moment strong evidence for when, although we believe that the earlier the better, I'm talking about ARDS, to initiate, or for how long to use corticosteroids in ARDS. And the second takeaways is whether dexamethasone is the corticosteroid of choice in ARDS, merit further studies. So thank you very much for your attention, and I hope you will enjoy